Good afternoon, everyone. Hello. Hello, Sonia. Okay. Please give me a feedback if I'm audible and visible both to you guys. Good afternoon, Dr. Sukanto. Really happy to see you over here. Good afternoon, everyone. Okay, I think so. Just a second. Right. Okay, so we would just quickly finish up the remaining topics in ortho that we were left with, right? And after that, we'll be covering up, like right now, I'll be giving a brief overview about the orthopedic images that we discussed into the previous class, because those are giving you straight exam questions that you cannot miss, absolutely, right? So once we finish the upper limb and the lower limb trauma and the arthritis, regarding the tumors, I've made like 2 pages. That's it. Just it's a flowchart. Go through it because there is nothing at this moment that you should be going into the details. So I've made it short, simple, and sweet. Just go through that. That's sufficient for you to solve 2 questions into the exams, right? Okay. And regarding the radiology, I'm not sure like if time permits today, so we will quickly overview the entire important radiological images today. I know I'm supposed to share you guys that file, but then we're left with a very small section in radiology, but those 10 images are giving you at least 2 to 3 questions in the exam. Yes, I hope you guys are aware about the head injuries, the EDH, SDH, SAH, DAIs, and everything, right? Okay. So I know this is a very peak time and you guys would be into the absolute pressure at this moment. Then it's fine. If it's a very normal, okay, just a second. Okay, right. So far I don't have anything right now. Okay, it's a very normal mechanism that we humans generally face. And we generally face this exam, to be honest, every day. This is just the beginning. Once you finish up this phase of this examination, the every day of your hospital practice is going to be a live examination for you guys. Okay, I know this is the absolute pressure. वो जो बोलते हैं ना कि सर पे से तलवार हट जाएगी, वो ये एग्जाम का प्रेशर. We all have been through this phase and we are absolutely aware कि ये phase में कैसे feel होता है. कोई बात नहीं है. It's just last couple of 10 days and then you would be done from this entire mess, right? Finally you will be relaxed and you will be making your family proud. ठीक है, चलो तो द मोटिवेशन सेशन एक बार अलग से रखेंगे. यू स्टिल हैव 10 days. एवरी डे यू विल बी नीडिंग मोटिवेशन एंड यू वांट समवन टू बूस्ट यू गाइस अप. विल बी डूइंग इट, नो डाउट, बट सर्टनली लेट्स फिनिश अप द प्राइमरी थिंग that we are left with. Once we're done with that, हम लोग आराम से बात करेंगे. बहुत सारे किस्से यार जिंदगी के, सब सुनते रहेंगे. कुछ आप सुनाओ, कुछ हम सुनाएंगे, और एग्जाम के बाद फिर बैठेंगे साथ में. नहीं 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 नहीं, मैं इंडियन हूँ. ओके, माय यूनिवर्सिटी, आई ग्रेजुएटेड फ्रॉम रशिया. Yes, I am an FMG. I thought many of you guys are aware about that. अरे कोई बात नहीं, कोई बात नहीं, यही तो चाहिए. राइट, करेंगे करेंगे, बैठ के अच्छा खासा डिस्कशन करेंगे. चलो तो आई थिंक सो द लास्ट टाइम there was some technical issues, so we couldn't like take the class to the utmost stretch. So we have finished like some of the fractures, the important fractures, right? The upper limb trauma हमने थोड़ा बहुत शुरू किया था, but don't worry, we'll be covering it up फिर से. I'll give you a quick overview. चलो एक बार हम लोग क्विकली रिवाइज करते हैं. This is the phase where you guys are absolutely aware about all the images, right? तो पहले हम लोग फटाफट images से शुरू करते हैं, right? Let's try to recall जो भी आपके स्क्रीन पे दिख रहा है. We won't take more than 5 seconds. I'm sure you guys are absolutely aware. ये फाइल मैं शेयर कर दूंगा in case if you guys have any doubts. You can still look upon to the images, the labelings, and then you can recall amongst it yourself, right? In your free time. Whenever you have it, do it according to your convenience, okay? No pressure at this moment. ठीक है, तो करें शुरू. Okay, just a small piece of advice. I know this would be the time आपको बहुत सारे सलाह मशवरे मिलेंगी, right? Like many advices people would be giving you, your seniors and everyone. But simple सी बात है, you have come till this path alone and you have faced it yourself, right? No matter how many people were there amongst like you guys, your families, your friends, your peer pressure, whatsoever it might be, but you made your decisions. You are over here because of your own decision making capacities, right? So just be calm, be focused on to what you're doing. Just keep one mantra into your head that I know what I'm doing and I know it is best for me. बाकी दुनिया भाड़ में गई, ठीक है? You do not care about anyone what is telling you. If someone is telling you, like giving you taunts कि तेरा whatever it might be, you might be a fresher, you might be a repeater, whatsoever it may be, it is not a race, it is a relay, okay? This race will never end. Even at the age of 60, 65, you still will be writing the exams, and this is how our profession works, right? तो पढ़ाई से तो छुटकारा है नहीं, तो क्या फर्क पड़ता है? द पॉइंट इज यू हैव टू क्लियर दिस एग्जाम, राइट? तो उसी के ऊपर आपको फोकस रहना है. बहुत सारे नेगेटिव थॉट्स आएंगे. Even if someone is telling you, either you leave that place or make that capacity within yourself कि जो भी है मुझे सिर्फ सुनना है, एक कान से सुनना है, दूसरे कान से निकल. You have made your plans and you have to execute it. I'm sure you, all of you are executing it right now and you guys are giving your best because हमें return में कुछ नहीं चाहिए. We just want one thing from you guys and that is you guys should pass this exam with flying colors. जो भी है, our main target is like टॉकिंग अबाउट द प्रैक्टिकल पिक्चर. यार हमारा बस चले तो हमें तो चाहिए कि जितने भी बच्चे सारे पास हो जाए, राइट? बट व्हेन वी टॉक अबाउट द प्रैक्टिकल पिक्चर, सब लोग ने बोला होगा कि यार जो भी मेहनत करेगा वो एग्जाम पास करेगा. नो डाउट योर एफर्ट्स विल पे ऑफ एंड दिस विल गिव यू जस्टिस एंड द जस्टिस विल बी द डे ऑफ योर रिजल्ट्स, राइट? आपका जो भी आप एफर्ट्स अभी डाल रहे हो, ये सारा कुछ आपके एग्जामिनेशन के एंड डे पे दिख जाएगा. एग्जामिनेशन हॉल से बाहर आते ही आप में वो कॉन्फिडेंस आएगा कि यस सर, ये बार तो मेरा एग्जाम क्लियर हो रहा है, ठीक है? ये कॉन्फिडेंस है मुझे चाहिए कि ऑन द एग्जाम डे व्हेन वी गाइज आर विथ यू, वी वांट ऑल ऑफ यू गाइज टू से दिस स्टेटमेंट कि नहीं सर, दिस टाइम आई एम मेकिंग इट हैपन. आई डोंट नो हाउ, वी डोंट नो, वी डोंट केयर हाउ यू विल बी डूइंग इट, बट ऑल वी वांट इज द रिजल्ट्स, ठीक है? व्हेन वी गाइज गिव यू सर्टेन इनपुट्स, वी ऑल्सो एक्सपेक्ट द आउटपुट्स फ्रॉम इट, राइट? चलो करें शुरू. Absolutely, absolutely. ओके करेंगे. गलेजी, मोंटेजिया, सब कुछ क्लियर करेंगे. ओके ओके चलो. एब्सोल्युटली, don't worry, you guys already have that MD or MBBS degree, whatever country you graduated from. It is just a milestone step that you have to give. That's it. It is just giving you a place in India, nothing else. No one is taking away the title of doctor from you away. You are still a doctor and you will be a doctor, okay? So ये चीज़ कभी भी दिमाग में मत लाना कि मैं डॉक्टर, अगर ये एग्जाम नहीं क्लियर हो रहा हूँ so I'm not a doctor. No, that's wrong. Whatsoever that reason might be, however you graduated, you still have that degree with you, okay? This is just a screening test that you're clearing up and you're making your platform. This is the beginning of the war, okay? ये तो बस अभी शुरुआत है, आगे के बड़े बड़े स्टेप्स तो इसके बाद आना है, ठीक है? So do not give up at this very moment. We still have a very long way ahead. Okay, chalo, let's start. Chalo, right now in front of your screen, everyone focus. What is the image onto your left and what is the image onto your right? Give me the two fracture, A and B. What is A and what is B? Anyone? Okay, let's answer A. What is A? What fracture is it? Name of the fracture. Come on. Nahin. Okay, fine. Someone said green. Okay, nightstick. Anyone? Okay, Kanika is still in a doubt. Okay, it's a nightstick fracture. And the one onto your right, it is the green stick fracture, right? इसके बारे में हमने बात की थी. We talked about this into the previous class. How do we differentiate? We look for the cortical ends, right? Like look at the cortex over here. दोनों साइड से it is distorted. It is being distorted from both the ends, right? So this becomes a nightstick fracture. It's a complete fracture. Fine. Now over here you can see this cortical end. It is intact. The one which is disrupted, it is this one, right? It is not a complete fracture. Yes, green stick fracture is your incomplete fracture, right? And this is green stick fracture. किसमें ज़्यादा common है? In what population do we see it is like the most common fracture? Green stick fracture. Absolutely right, Azhar. Everyone. Yes, it is much more commonly seen into children. Why? दोनों कॉर्टेक्स क्यों नहीं ब्रेक होता है? बिकॉज दे आर स्टिल इनटू द डेवलपमेंटल फेज, राइट? तो उनका बोन उतना स्ट्रांग नहीं होता है. वी नो दैट दे हैव मेटाफाइसिस, द फाइसिस, द ग्रोथ प्लेट, इट इज मच मोर हाइपर एक्टिव, राइट? सो उनके बोन्स कंपेरेटिवली अडल्ट बोन्स दे आर कंपेरेटिवली स्लाइटली सॉफ्ट, राइट? ओके, नाइटस्टिक फ्रैक्चर जनरली दिस वन is happening in which bone? Radius or ulna? We talked about it. I gave you a description. Remember in the last class, how is it happening? We just place our hand. This is the protection mechanism. Party में club करने जा रहे हो, right? You have a fight with someone, and if someone is trying to punch you, how do you defend yourself? Right? This is the how you will be protecting yourself. So when you do that, and if someone is hitting you, कोई यहाँ से अगर आपको मार रहा है, तो यहाँ पे जो bone आपका break होगा, which is this bone? यहाँ से medial aspect है, अभी ये lateral aspect में, right? So this is your ulnar bone. Ulnar bone break हो रहा है. Fine? Okay. This is the only confusing image generally people get confused upon. I hope you guys will not make a mistake in the exam, right? Okay, moving forward. One of your favorite ones. Give me the name of the bone and the fracture. Come on, we have done it before. सब लोगों को पता है कौन सा है? चलो बताओ. What fracture is right now in front of your screen? चलो come on, फटाफट. Give me quick overview क्योंकि इसके बाद हमें 3 important topics करना है. Giving you at least 7 to 8 another questions for the exams. Scaphoid, Salter, Harris. It is your Schoffer's fracture. What part is getting affected? This bone is which bone? This is the radius. This is the ulnar. What part is this one? This is called the styloid process of your radial bone, right? So now if you look over here, this part is getting fractured. Now, why is it called chauffeur? Chauffeur does what? It parks your car, right? Like, or the one who drives your car. So when you are onto the steering wheel, this is how you rotate, right? So this is, जब jerk में अगर कोई movement होती है, if this movement happens in quite a jerk, there is a high possibility that the styloid process of your radius bone can get fractured, right? Okay. I hope everyone is clear over here. Okay, moving on. Chalo, fatafat. Let's come over here. Okay, what structure of the anatomical body is this? Tell me, is it the upper limb or the lower limb? Upper limb or the lower limb? Come on, everyone. All right. Is this the upper limb or the lower limb? Upper limb. Perfect. Okay. When we talk about the upper limb, what is this structure? आप लोग बोल रहे हो अगर अपर लिम्ब है तो चलो मान लिया ये आपका अल्नार हो गया, ये आपका रेडियस हो गया, तो ह्यूमरस है कहाँ पे? ये फ्रैक्चर का नाम बता दो. कम ऑन, वी हैव डन दिस बिफोर आल्सो. गिव मी द नेम ऑफ द फ्रैक्चर. एनीवन? फ्लोटिंग एल्बो. ओके, इट्स अ फ्लोटिंग बोन actually. Humerus is missing, absolutely right. Give me the name of the fracture. It's not the olecranon, it is associated with your ulna. This is just a particle of the remaining fragment of your humerus bone. The name of the fracture is Carr's sideswipe fracture, right? This is much more common in children. Okay, another one. Moving on. What is this fracture? Give me the bones. Give me the name of the bones. What do you see on front of your screen? Sideswipe or Carr's slide fracture, okay? One and the same. मतलब basically इसमें क्या हो रहा है? बचपन में जब बोलते थे, right? When your mom and dad used to tell you that do not take your hand outside the car window, right? So when you keep this in this position and when something hits you, the force is so strong that a bone like humerus comes outside. Over here, the humerus is displaced completely. So this becomes a which kind of a fracture? It's a open fracture, right? So over here, how this can be fixed? We cannot fix it by close reduction. We'll have to do open reduction, right? This is how we'll be fixing this because पूरी हड्डी आपकी बाहर आ गई है. When you keep the hand like this, पीछे से कोई कार आके अगर hit कर रही है, pressure की वजह से this humerus comes out like this. So imagine this is the humerus. Now it is coming out like this. Okay? Now when it comes out like this and when you take a X-ray, obviously when the bone is not into the picture, how can you see the humerus? That's the exact picture you're seeing in front of your screen, alright? Okay, chalo. Give me the name of this fracture. These fractures are giving you at least 2 to 3 questions, okay? Very important for your exams. And 1 or 2 surely from your splints. Okay, what bone is it? Give me the name of the bone. Which bone is this? Bumpers fracture, everyone. Okay, absolutely right. I want everyone's participation and no one's making a mistake at this point of time because look, these are the minor subjects where you will be scoring more. This is the misconception. People think medicine पढ़ ली, surgery पढ़ ली, obs gynae पढ़ ली, कितना भी पढ़ लो वो subject कभी भी खत्म नहीं होने वाला, right? It's a very vast specialization, right? And you cannot challenge the examiner into these subjects. Obviously, you can get 70 to 80% of questions right, but into these minor subjects, you can get all the 100% questions right, right? I do not expect anyone to make any mistakes into radiology and orthopedics, at least when it comes to the image-based questions. Definitely, you will be given different cases. When I talk about the fractures, we have discussed about the complications of the fractures into my previous videos. Have a look upon to it, like what are the complications, ARDS, fat embolism syndromes, right? DVTs, into what fractures and how is it associated, avascular necrosis. You're surely getting 1 question out of this into your exam, okay? Chalo, this is your bumpers fracture. Absolutely right. This is the tibia, which is getting fractured over here, right? Okay, fine. Moving on, I know this image might not be clear. I'll give you a hint. There is a fracture over here and one over here. Give me the name of the fracture. This is a confusing image. Look over here onto the screen very carefully. We'll be coming back onto this image again and look upon to this image, right? Over here we have 3 aspects. This is the AP view, right? The lateral and the medial and the posterior part of the tibia. It is getting fractured. Now tell me, the lateral medial malleolus and the posterior aspect of the tibia, they are getting fractured. Over here we have 3 locations of the fracture. Over here, if you can see, this part is absolutely intact, right? Nothing is getting damaged. Give me what is A, give me what is B. Give me the name of A. What is the name of the fracture? Potts fracture. Absolutely right, Pratibha, Pramod. It is Potts fracture. So A becomes your Potts fracture. What is B? Trimalleolar. What is the other name of trimalleolar fracture? Cotton fracture. Absolutely right. Alu, Pratibha, Snehal, everyone. Okay, chalo. Moving on. Over here, just focus onto this image over here, all right? Look over here. If you look in front of your screen, can you guys tell me, is it a extra articular fracture or a intra articular fracture? मतलब इसमें joint space involved है या नहीं है? Joint space involved है या नहीं है? Come on, everyone. Yes, okay, fine. इसमें joint space involved है. This is a classical example of a intra-articular fracture. This is the first image that we are seeing for today, which is an example of a intra-articular fracture. इसका मतलब क्या हुआ कि आपका जो movement है, motility जो है, ये distorted है. Over here, can you preserve the joint movement very easily? No. It is a very complex fracture. Okay. Just a quick question from the radiology, if you guys have attended. Give me the name of the investigation that I have just encircled. We have discussed this into radiology. Anyone who can answer this correctly to me? Chalo. It's a 3D. Karthik Parekh, absolutely right. It's a 3D CT scan. This is a colored CT scan. We call this thing as a 3D CT scan. Okay. Okay. This is fall from your height, called as the pylons fracture. All right. Okay. Chalo. I think this one might be a bit clear. Okay. Right. So if you see over here, the joint space is distorted, right? It is obviously a fall from height. Can you see over here? It is the same picture. So what we do is we will cut open. This cannot be possible with close reduction, right? इसमें तो surgery करनी पड़ेगी. That's the reason we'll be cutting the patient open. We'll be fixing it, but do not get into the details कैसे करना. At the moment, not necessarily know the type of fractures. We'll talk about it when you'll be preparing for your PG, all right? Okay, chalo. The tela, okay, this is very obvious. The name itself is given over here. The anatomical structure is the talus, right? It is the neck of the talus. What is the name of the fracture over here? Talar neck fracture. Come on, give me the name. What is the name of the fracture? Anyone? It is your aviator's fracture, okay? This fracture is called your aviator's fracture. Okay, moving on. Now, if you look into the picture, look over here onto the base of the fifth metatarsal joint. Can you appreciate this structure over here that I'm highlighting right now? Okay, this thing is distorted. What is the name of the fracture over here into this image? Okay, this is your Jones fracture. Okay, remember Jones fracture involves your fifth metatarsal joint. Okay. Okay. Right. What is the name of the fracture over here? Give me the anatomical structure that you see right now in front of your screen. Okay, if you pay attention over here, can you all appreciate this anatomical structure? It is the odontoid process, the dens, which is seen into the cervical second vertebra, C2. So obviously this one that you see over here, this is C1, right? So over here, the C1 is getting fractured, right? This is your Jefferson's fracture. Absolutely right. Okay. We have discussed this thing before also. Okay. If you guys pay attention over here, I'll be showing you another classical picture over here. Look over here into the picture right now in front of your screen that I'm just drawing. Can you see the body of the vertebra? It is getting fractured from the anterior to the posterior aspect, but there is no change into the length or the width of the vertebra, right? Can you see that part? The spinous process is getting, yes, it is getting distorted, but this is a classical example of a chance fracture seen in seatbelt or the car injuries. Okay. Okay. Now, this one over here, it is also associated with one of the fractures we discussed, that is your pylons fracture, right? The fall from the height or into the burst injuries. Now over here, look over here into the vertebral section. Can you guys see that आप लोग सब लोग देख सकते हैं कि यहाँ पे वर्टेब्रा इंटैक्ट है, इसके लेंथ विड्थ हाइट में कोई डिफरेंस नहीं हो रहा है. नाउ लुक ओवर हियर, लुक ऑन टू दिस वर्टेब्रा. Now compare it with this one. This is in your burst injuries or fall from height, called the burst fracture. Okay, what happens over here? There is decrease in height and there is increase in width, right? I hope everyone can appreciate what you're seeing right now in front of your screen. Okay, chalo, moving on. Anyone, I hope everyone is aware now after attending the radiology class that this investigation that you see in front of your screen, it's a CT scan and it's not a MRI. Why? Because you can see the cortex of the bone clearly visible, right? The cortex is clearly visible, right? Okay, chalo. This generally is much more commonly seen in C7 more than T1. Okay, Clesh-Ovler's fracture. We discussed this before also. There is a classical reason why this fracture happens. Clesh-Ovler's मतलब कुछ नहीं, इंडिया में जो कूली का काम करते हैं, when these are the people who empties those lorries, right, big trucks. So they use that hook kind of a thing, right, जो गोनी को उठाने के लिए ऐसा hook करके they pick it up like this, right? So when you do this, you get a jerk over your back, and the spasm is so strong that it might even fracture the spinous process of your cervical vertebra. Why? Because what anatomical structure we have over here, one of the most strongest muscles, it is your trapezius muscle, right? So it's because of that we get this fracture. Okay, moving on. This is, everyone is aware about translation of C2 over C3. This is your hangman's fracture. Okay, this is much more common in which type of hanging? Can anyone tell me? Hangman's fracture. Is it much more common in a typical hanging or a atypical? What do you mean by typical and atypical? Chalo, let's revise forensic. Atypical, absolutely. So where is the knot of this? Where is the knot placed when we talk about this suicidal method or this type of punishment, which is the judicial punishment method in India for the death? Side knot. It is placed where? The knot of the rope is placed where? At the angle of mandible, neck of mandible. Okay, I'm hearing it for the first time. It is at the angle of mandible. Okay, all right. Chalo, so make sure you do not get confused between this one. This is your Jefferson's fracture, arc of C1. Okay, arc of C1. Look for the odontoid process or the dents. You will get a clear picture if it's a Jefferson's fracture or it's a hangman's fracture. Hangman's fracture कहाँ पे हो रहा है? C2 over C3. Translation of C2 over C3. Right? Okay, chalo. I hope we are clear over here. Okay. Can anyone tell me what is happening over here? Is it a fracture? Is it a dislocation? What do you see right now in front of your screen? And we talked about one thing. Anyone who can give me the name of the line? A treat from my end. Come on. This will give me a proof if you guys are absolutely aware about this or not. What is the name of the line? Can you see over here that ये जो angle है, ये intact है. This angle is absolutely intact, right? It's somewhere close, Vivek. It is Shankston's line. Okay, Shankston's line. So if the Shankston's line is getting distorted, that you see right now in front of your screen over here, see if you make this angle, you can see this gap over here, right? It is getting distorted. Why? Because the femur, it has been dislocated to the posterior aspect of the hip. This is much more common when you have a car injury, right? Car injury जब होती है, when your leg is onto the accelerator, when you get the reverse pressure hitting up onto your car, you have a very high tendency that because of the velocity, the head of the femur, it's going to get dislocated, it's going to come out of the capsule, it's going to move to the posterior aspect of your pelvis, right? Okay. Chalo, moving on. Let's quickly revise the splints over here. Chalo, everyone knows this one is your, come on, give me the name of the splint. K-wire or the camera wire, right? It is used to immobilize the patient immediately. In any injury, or if you suspect any kind of a fracture, immediately onto the street. This is the best or the most oldest method of mechanism to prevent or to support or to immobilize the limb if you suspect a fracture or injury happening over there, right? It is also used to immobilize any kind of hip fractures, right? When you see hip fracture mein kya hota hai? Obviously the leg is rotated. Okay, the leg is internally rotated. It is internally rotated, and this one, the thigh part, it is abducted, okay, not adducted. Okay, fine. This is your Thomas splint again, used in femur and hip fracture, okay? Right. Who is the father of orthopedics? Come on, you guys have it in front of your screen. Sir Hugh Owen Thomas. Okay, absolutely right. Chalo. This is one of your exam questions. CTEV, congenital talipes equivaris. Can anyone tell me what do you mean by that? It's the, okay, clubfoot deformity. Fine. Agreed. This was one of your exam question. What is the name of the splint that we use? This is your examination question. Dennis Brown splint. Okay. If you, give this support to the child into the early ages, there is a high chance you can correct his CTEV, right? The equivaris, the talipes equivaris. What do you mean by the term varus and valgus? Let's quickly revise this. Okay, let's do this. Valgus and varus. It's very easy. In case if you keep on forgetting this thing, remember this principle. L is length, lamba, okay, long, okay. This is reduction. R is what? Reduced. So when you make an angle, if you say, okay, normally we have it roughly around 125 degree. Okay. This is the angle about your femur and the entire leg. This is, I'm talking about your lower limb, okay. The angle that is being framed at your hip joint, it is around 125 degree. Now, if this angle is increased, say this is 145 degree, this is increase in angle, and this is decrease in angle. Say this is 95 degree. Basically, when you look over here, so this one is decrease in the angle. So this is what I mean by the term L is for length, R is for reduced. Long, reduction. If the angle is increased, this becomes your valgus. If the angle is decreased, it becomes your varus. Now what we're talking about over here is equivarus. So when I talk about the term equivarus, you should know that the angle is decreased over here. Okay. I hope this one is clear amongst you all. Okay. Perfect. Chalo. Let's move on ahead. This is your cock-up splint. Come on. Everyone knows wrist drop deformity. What nerve is involved over here? Much more commonly seen, it is your radial nerve. And what are the two important muscles it is supplying over there? When this condition is involved, when the wrist drop is involved, extensor carpi radialis longus, extensor carpi radialis brevis, right? Okay, chalo. Next, moving on. This is for your lumbricals. Give me the name of the nerve. I'm just mimicking you guys the condition, how the patient is going to come in front of you. Give me the name of the nerve. Let's quickly revise a bit of your anatomy. Give me what nerve is involved over here. Ulnar. Give me what nerve is involved over here when I do this. Median. Ulnar, median. When I do this, this is the complete. Okay, this is the partial, this is the complete. This is semi-partial, but you can say we have so many tests over here that we'll be discussing about the pen test and the card test where the median nerve is involved, right? Okay, we conduct these tests to make sure that the patient is having this deformity or not, right? So we use this knuckle bender splint, right? So in this way, what happens is we try to put up the pressure onto the patient so he can get his nerve sensation back, okay? All right, fine. This is your, come on, can anyone tell me in what condition is this one used? VIC, your Folkman's ischemic contracture. What happens over here? There are two important muscles which are involved into this condition. Okay, just giving you a brief overview. It is your flexor carpi ulnaris and flexor digitorum profundus, FDP, right? It is a example of a composite muscles. Which two nerves are supplying that muscle? Yes, it is both your radius and your ulnar, right? Okay, chalo. Now what happens over here is when you apply this splint, turnbuckle splint, so basically now you know that the best management over here, this can be also complication of the compartment syndrome. आपने fracture लगा दिया, you applied the fracture to that patient, but you apply it so tightly that the intravascular structures and the subcutaneous structures, the muscles, the vascular tissues, the fascias, everything gets compressed, right? Now, if you want to relax that, blood vessels are always surrounded by a sheet. Everyone knows that, right? It is the sheet that in which your blood vessels and your nerve endings or the nerve supplies, they are enclosed, right? So now when you know that the patient is having this condition, if you do not fix it, he's gonna go into what? Avascular necrosis जो चीज़ें हम लोग बोलते हैं, right? They will be decreased into the blood supply. This will become necrotic. Basically, there won't be any work of this thing. Now, when the fibrotic changes happens over here, it will turn it into myositis ossificans. What is the meaning of myositis ossificans? Basically, your muscular structure, it starts getting ossified or calcified. You guys have absolutely studied this in pathology, right? So this is one of the severe complications. So to avoid this condition, we apply this splint when we open the fracture so that the patient eventually it's like a knuckle. It's like a hook kind of a thing, okay? Every 5 days or a week, we keep on releasing the pressure, and this is how the hand's gonna go up. It's like this, it's tight. Then we turn the buckle. This is at week number 1, week number 2, week number 3, week number 4, right? So this is how the patient can get his movements back, okay? All right, sure. Moving on, this is one of your favorites, Erb's palsy or aeroplane splint. In which injury? Airplane splint. Brachial plexus is involved. Axillary, right? Okay, chalo. This was also one of your exam questions. Involved into the lumbar vertebra or the thoracic spinal injuries or into the TB spine. Also, we use this splint. This is your Taylor's brace. This is giving you absolute support to your back, okay? These are the aluminum rods which are being placed over here. This is giving you, helping you to manage an intact posture for your back. Okay, chalo. This is for the scoliosis. What is the name of the splint? Milwaukee's and Boston's, right? It is Milwaukee's and Boston's brace. This is for the scoliosis. Now, foot drop. What is the nerve which is involved? Common perennial nerve. Foot drop splint. Foot is like this, okay? It's not that the splint is helping the foot to hyperextend or to dorsiflex, but basically what's happening is it is the plantar flexion of the foot which is happening over here. Because of this splint, the foot is staying intact, okay? It's something like this. All right. So, okay, this was also one of your exam questions, developmental hip dysplasia, DDH, or the long dislocation of the hip. We use this if you have, okay, this is the same classical picture that you'll be seeing in front of your screen into the exam. We'll be having a child. Do not get confused between, okay, what is this one? Your CTEV, Dennis Brown splint. It involves the foot. Over here, this involves the hips, right? This involves the hips of the child. What is the name of the splint? Barlow's splint or the Pavlik's harness, okay? Okay, fine. Right, we'll be talking about these tractions, the Gallows-Bryant's traction involving into the children when they have the shaft of the femur fracture. And also one of the most important ones, we'll be discussing it when we'll be doing the upper limb and the lower limb traumas, okay? This is the Dunlop-Smith traction, okay? What do you mean by the Dunlop-Smith traction? This is a very important fracture that we'll be discussing. Can anyone tell me there are 2 fractures of necessity? A classical 5-star question. Anyone who will be answering me this question? Okay. A treat from my side. Fracture of necessity. There are 2 fractures. Can anyone? One is your supracondylar fracture, or is it the lateral condylar fracture? Epicondyle. Okay. One is your lateral epicondyle fracture of the humerus. So basically, this is the humerus bone. Okay, considering this to be the medial aspect, this to be the lateral. When you have a fracture over here, this is one of your fracture of necessity. The other one is your Monteggia fracture. Absolutely right. It is the Monteggia fracture. These are the two fractures which are called as the fracture of necessities. Okay, we'll be discussing this thing into details. Do not worry about that part. Okay, sure. Let's start with the traumas that we could not do it. I hope this quick revision was helpful for you guys. We just tried to finish it off into 30-35 minutes, but I hope when you'll be revising it, you won't be taking more than 5 to 10 minutes to revise that, right? Okay, fine. Make sure that you also go through the file that I've shared it to you into the previous discussions. I have written down all the eponyms for the fractures, right? Just as the one-liners. Look into the file, look into the image, look into that section, quickly recall, okay? That way you're recalling almost 10 to 20 different types of fractures, right? Sure. Okay, upper limb trauma. Come on. Let's get started. Everyone knows what is the most common type of injury or the most common dislocation that we see into the body, which is that one. Yes, I know. That's the reason I'm giving you the content. I know I keep getting it from everyone. I'm really sorry. I try really hard to not make it worse, but then this is the best I can do. All right. But I hope you guys are understanding the concept. I will really appreciate if someone can make some notes for me, because that way I can deliver the best content. But then I'm sorry, I cannot help. This is how I write. All right. Okay, fine. Chalo. Moving on with the dislocations. Okay. So when we talk about the most common joint which dislocate in the body, it is the shoulder one. Obviously, baat hai, we play generally, it is much more common into the elderly population and the children. How do we have discussed this into the previous class also, right? How this happens when someone falls onto the outstretched hand, right? What do you mean by the outstretched hand? Now, let me try this. Okay, I hope this part is visible over here. Okay, now if someone is playing, how do you fall? What is the defense, excuse me, the reflex that we get when someone falls? This is how this happens, right? We will stretch, bahar haath nikalta hai, right? This is how you will extend your hand, right? Just to get a support. So when you fall, you do not fall straightly on your face. So when someone falls on the outstretched hand, look at my hand very carefully. Can anyone tell me, are you all with me? Can I say this is abduction? This is adduction, right? So this is internal rotation. This is external rotation, right? So when you take your hand out, can I say this is external rotation, abduction, right? This is how the position of the hand is, right? And when you want to fix it, how you'll be doing it? Obviously, this thing has come outside the capsule. Now, when you want to put it back, it's easy. You do not need to cut and open, right? Give some anesthesia. Try to do the opposite. Okay, you can try to stretch it out more. Give some weight traction. Adduct. This is adduction. पहले हाथ को अंदर लाना है. Adduct करो, then internally rotate it or medially rotate it. This is how you can get the upper limb back again to the position, right? Okay, I hope you guys are with me into this. Right. Okay, chalo. So we'll be discussing how this thing happens when you fall on the outstretched hand with the limb in abduction. This is the exact thing I've told you, abduction and external rotation. Okay, we'll not be wasting too much of time. I'll be sharing you these notes in case if anyone wants to read, you can read, but look upon to the highlighted points and the images. That is more than enough at this point of time. All right. Okay, this will definitely help you clear many questions. One of the important, which is the much more common into all these three types, is the subcoracoid process one. It is this one that I'm highlighting right now, the B. Can you all appreciate this to be the coracoid process, right? So when you look over here, this is your coracoid process. This one, this location is right beneath it. That's the reason it is subcoracoid, which is the most common one. Okay, your coracoid process has got so much of significance into many other management methods as well. We'll be discussing about it. Just try to remember this anatomical structure. Okay, fine. So these are the three types. Preglenoid, थोड़ा सा glenoid के आगे आने पे preglenoid. When it comes furthermore, this comes under coracoid process, right? Scapula का एक part है. Just revising your anatomy, ठीक है? So now, if this dislocation is onto the, we are talking about the anterior aspect only right now. So when it is onto the anterior aspect, just below the coracoid process, this is your subcoracoid. Now when it moves further on, this comes below the clavicle. That's the reason it is sub or the infraclavicular type, right? But the much more common one is subcoracoid, much more common, right? The management is also something that I've discussed. Let's quickly look upon to the management first. As I told you, we can do close reduction. खोलने की जरूरत नहीं है. What do you mean by close and open reduction? Open reduction is basically giving an incision. आप ऑपरेशन थिएटर या ओटी में वो पेशेंट को मैनेज कर रहे हो. Close reduction is you're not giving any kind of incision over here, right? Okay, fine. So obviously it is under sedation, pain hoga, so you give anesthesia. This is what I told you. You give some traction, you further rotate it slightly more. Team is the, right? This is the mnemonic that we have made for this management. Now this is abduction. Now you have to adduct. पीछे लाना है तो adduct करो. This hand was already externally rotated, right? This hand was already externally rotated. Now what you have to do is, अब ये abduction में, this is abduction, original phase, right? Abduction, this was externally rotated. Now to fix it, you will be internally rotating it back again. ठीक है? Okay, fine. चलो. And what happens with the complications? Okay, there is a test. Now, if you want to differentiate, let's talk about it once we discuss the posterior one as well. Okay. Now, it's a classical sign. Everyone knows posterior dislocation of the humerus. It's a classical examination question. The light bulb sign. The light bulb sign is classically seen in the posterior dislocation of the humerus head, right? Okay. It is much more common into three conditions. You might get a case like elective convulsive therapy was undertaken upon a patient having some psychological disorders. And during the management, it was observed that the patient dislocated his arm. Given below is the radiological image right now in front of the screen. Can you identify or investigate which type of dislocation is it? Is it the anterior one, A? Is it the posterior, B? Is it the infra? Or is it the fracture, right? So the absolute picture, even if this one is given to you into the clinical case format, you should know that if the patient is undergoing any kind of therapies, electroconvulsive therapies, or into the epilepsy basically जो बोलते हैं ना दौरे आना patients में, into these cases also we see these kind of fractures which generally commonly takes place, right? So this involves the posterior dislocation, but the important one is your anterior. This is much more commonly seen into your practice. Which one? The anterior dislocation, right? Chalo. So now it is a very simple clinical test which can also help you differentiate between the anterior dislocation and the posterior one. It is called the Dugas test. What you do is you just ask the patient to touch the opposite side of the shoulder. जब anterior dislocation हुआ है, okay, just imagine this to be the head of the humerus, okay? Now this one was intact over here, okay? This one was intact over here. जब वो anterior part में आ रहा है, can I say the humerus का head अब यहाँ पे आ गया आगे, ठीक है? Now when the head is over here and when you ask the patient to touch the opposite end, can I say that the head will move like this? ये जो head है ये यहाँ पे, ये अंदर की तरफ rotate करेगा, right? When you try to touch the opposite end, the humerus head will try to move into the capsule. But जब वो capsule से बाहर आ चुका है from the glenoid cavity से वो जब बाहर आ चुका है from the capsule, right? How is it possible that it gonna touch the opposite or the other end of the shoulder. It's highly impossible. The patient will cry out in pain. He might even kick out your balls, right? So this is how painful this condition is to those patients. So into these case, the Dugas test will be positive. The patient will be unable to touch the other end or the opposite end of the shoulder, right? Okay, a very classical test. We do it into the clinical practice, even if you do not have any other option for any, say, radiological investigation. This is the best thing you can do. Although it is highly advisable to get X-ray done before you confirm any diagnosis, but this is the clinical confirmation sign that you can be doing into these patients, right? Now, obviously, बात है कि when you have a dislocation, there is a high chance कि वो फिर से dislocate हो सकता है, because the cavity now gets loosened up. So now when recurrent dislocation happens, recurrent anterior dislocation happens. Simple, probably this might be bit, no, this is black, okay, fine. Let's work according to the contrast, right? चलो, तो अब ये आगे की तरफ आ गया. Now when you would be moving your hand, जैसे ये movement कर रहे हो, right? So can I say कि जो head का पीछे का part है, right? When you would be moving your hand बार बार, okay, I'll just draw it in front of your screen to make you understand this thing better, right? Okay. Now suppose in this way you have the normal bone over here, right? Can everyone appreciate this? Now when this thing gets dislocated, तो ये पूरा entire structure, how is it gonna be visible to you guys? Into the anterior aspect में ये ऐसा कुछ हो जाएगा, right? Now what happens is when this patients try to move their hand, focus over here onto this aspect. This will be giving you a PG question and a FMG question. Now what happens into this condition is when the patient is constantly having 3 or more than 3 episodes of anterior shoulder dislocation, he will be injuring the trochanter's of the humerus, right? Okay. Now let's discuss this. We'll be coming on to this image, the same exact image. Now let's understand कि इसमें सबसे पहले क्या होता है, right? Now the pathological lesion, the first one that you see is the labrum is gonna get distorted over here. If you can see over here, the labrum, the Bankard's lesion happens in 90 to 95% of the cases. This is the much more common version that we see into the anterior recurrent dislocation, 3 or more dislocations. ठीक है? Much more common into the anterior inferior aspect. Okay. इसका management भी, over here we have the Bankard's lesion, over there we have the Bankard surgical method that we conduct into these patients to manage the Bankard lesions. Okay, we'll be coming on to that also. The another complication is the Hill-Sachs lesion. This is classically seen on a X-ray or a CT scan. One of your important examination questions. Hill-Sachs lesion is the bony defect in the posterior lateral aspect of the humerus. Now you'll be like कि अगर ये statement पढ़ रहे हो कि ये posterior lateral humeral head है क्या? Let's come on to this picture again. अब कुछ picture समझ में आया कि when the humerus, आपका जो पूरा bone है वो anterior aspect में dislocate हो गया. Now when you will be constantly moving your hand, focus onto the highlighted part. Won't you be damaging this bony aspect over here, right? यहाँ पे specifically this part, because this is the sharpest part, this part will be getting distorted. You will be having this kind of a picture. Now let's try to see it, how does it look into the radiological aspect. Can you see the depression over here? This is your classical Hill-Sachs lesion, okay, which happens into recurrent dislocation of the humerus. Which side of the dislocation? Anterior dislocation of the humerus. Okay, fine. Now when this bone part is involved, okay, I don't know what's happening, just a second. Okay, all right, perfect. Chalo. So what is the management that we'll be doing? Obviously when your labrums are involved, okay, labrum is what? It's a soft tissue. So what would be the investigation of choice over here? Can I say it's going to be an MRI, right? Because it's a soft tissue. Now, before you want to undergo any kind of arthroscopical management procedure, you will be undergoing an investigation, and that would be an MRI, right? So once you get a clear picture, you would be doing arthroscopic Bankhart's repair. Basically arthroscopic Bankhart's repair में आप क्या कर रहे हो? What do you do over here is आप सिर्फ लेब्रम को फिक्स कर रहे हो. लेब्रम जो बाहर निकल गया है, ये जो पार्ट आपका जो फट चुका था, ठीक है, इसी को आप स्टिच कर रहे हो. ठीक है, यही पार्ट को आप स्टिच कर रहे हो. यू आर नॉट डूइंग एनीथिंग एल्स ओवर हियर. ठीक है. नाउ इफ यू लुक ओवर हियर, the another method is your Bristol-Attarded procedure. Now what do you mean by your Bristol-Attarded procedure? When the recurrent dislocation happens, okay, there is a high tendency that you will be breaking the preglenoid cavity as well. The bony structure of the glenoid fossa will get broken, right? This is how the glenoid looks like. Fine. तो ये अगर break होता है, and if you try to put the joint back again, now imagine this to be the bone again. Do you think it's going to stay intact? No, obviously बात है, अगर bone cavity ही intact नहीं है तो bone को फिर से आप replace करके भी कोई मतलब नहीं बनता. There is no sense into that. That's the reason now when you want a bone, you would be like, now the bone is missing. How would you replace it? Over here comes your cricoid process, right? Okay, I hope everyone can appreciate this structure. So what we do is we cut a bone from over here. Okay, this is the upper limb ka bone bank. We cut it from there, and say if this part was broken, right? So we cut that thing from there and we try to fix it over here, and then we put the humerus back again into the capsule. We're making an artificial capsule, okay, and we're putting, or we are replacing that thing back again into it. Okay, fine. So these were some of the managements for your anterior dislocations, right? Okay, chalo. Now moving on to the fractures. We are done with the dislocations. Moving on to the fractures of the shaft of humerus, right? We have some of the important terms over here. Shaft of the humerus, or what do I mean by the shaft? It is the diaphysis, right? The diaphysis is also known as the shaft of any bone. Okay, the most commonly, okay, if it happens at the diaphysis, obviously baat hai, what is the groove over here? Groove for the radial artery and the nerve, right? This is passing from over here. So we will be affecting that part. If it happens onto the proximal aspect, we'll be damaging the axillary nerve. If it happens towards the distal end and say towards the medial aspect, the medial epicondyles, what is the nerve will be damaging? The ulnar over here, right? And if it happens exactly into the center, right, we also have that condition. What nerve will be affecting over here? The median nerve. Absolutely right. Chalo. Okay. So over here, when the radial nerve is involved, what happens is wrist drop. And what is the splint that we use? The cock-up splint. I hope everyone remembers and appreciate these two muscles because they have been supplied by the radial nerve, right? Okay, sure. Am I proving my point over here? If it's the proximal humerus, what nerve are we injuring? The axillary, right? Into the radial nerve, it is to the shaft or to the diaphysis. If it is medial or lateral, it depends on what part distal it's affecting. Towards the medial aspect, it's the ulnar nerve, right? Fine. Sure. So when these fractures happen, now you would be like, everyone would be thinking that this is a very common thing that you generally see कि किसी का हाथ फ्रैक्चर होता है तो उसको पीओपी का कास्ट लगाया जाता है और उसे बोला जाता है, right, like to wait for 40-45 days, right, to get another x-ray done and to see if the bone is getting healed up or not. But did you guys anytime question कि ये position क्यों दी जाती है? Okay, when you say you want to leave it to the gravity to build up a pressure or to build up a traction, now how are you giving up the traction? फ्रैक्चर यहाँ पे है, ठीक है, तो जाहिर सी बात है आप तो यही सोचोगे कि अगर ट्रैक्शन लगाना है तो ऊपर से कोई प्रेशर लगना चाहिए, राइट? बट अगर आप ये चीज कर रहे हो तो ये इंटैक्ट पोजीशन नहीं है. नाउ इमेजिन इफ समवन इज होल्डिंग माय हैंड ओवर हियर, तो मेरा प्रेशर क्या रहेगा, यहाँ पे रहेगा, मेरा शोल्डर का अपर प्रेशर नीचे ड्रॉप हो रहा है, बट वेयर आई एम रेस्टिंग माई फोर आर्म ओवर समथिंग, आई एम exerting a reverse pressure towards my arm. Are you getting my point? So this is how these fractures work, कि यहाँ पे break हुआ है, यहाँ से तो वो hang हो रहा है, but when you tie up these knots or this support onto the forearm, this exerts a reverse pressure, and this is how the fractures get healed into the shaft cases. Okay, fine. What are the general complications that we see over here? Okay, it takes roughly about 7 to 9 months that we decide that if any kind of malunion or non-union is happening. अगर वो चीज डेवलप होती है, so what we'll have to do is we'll have to cut open the patient. Obviously, we'll have to fix the bone, we'll have to replace the bone, and we'll have to fix it with the pedicle screws, right? Fine. So everyone knows the iliac crest is your bone bank into the body. Okay. So now moving on, one of your another important fractures. Can anyone tell me what are your supracondylar fractures? Are these your intra-articular fractures or the extra-articular fracture? Come on, anyone? Intra-articular fracture or extra-articular fracture? Okay. Okay. Absolutely right, Gopal. It is a classical example of your extra-articular fracture. Can you guys see that यहाँ पे joint space intact है? ये joint में कोई दिक्कत नहीं है. Fracture हो रहा है ऊपर की तरफ. The fracture is occurring onto the superior aspect, right? The supracondylar, above the condyles. Okay? We'll be coming on to that one also, the intra-articular one. Now have a look onto this one. How these fractures look like. It is a classical example. These are your pointers of your exam. Distal humerus metaphysis just above the condyles. So what happens over here is, now say this, right, chalo. So this is happening at where? The metaphysis. What is the metaphysis? Can I say that the part I'm highlighting, this part becomes your epiphysis? Bachcho, like if it's a child, we will be having physis over here, and this is your metaphysis, and comes your diaphysis over here, right? So these fractures are involving the metaphysis of the bone, right? Supracondylar are involving the metaphysis of the bone. It's an extra-articular fracture. What do I mean by extra-articular? Joint space is intact. Okay, there is absolutely no problem into the movement. Okay, the joint space is intact. कोई problem नहीं है synovium से, right? Okay. Fine. This can be also much more common into the fall onto the outstretched hand. Can anyone tell me there is one more fracture which is much more common when there is a fall onto the outstretched hand? ये कौन सा वाला fracture है? कोई बता सकता है? It's one of your very famous fractures. Gopal, absolutely right. Twinkle, absolutely right. It is the Colles fracture. Okay, we'll be coming on to that also. Okay, fine. Right. So I hope everyone is clear about this picture, a supracondylar fracture. Okay, fine. The displacements, medial, posterior. Okay, these are not your exam questions. You can read it. We have talked about it into the previous class also. We'll be just discussing the important points. Okay, now this is one of your important concepts, the 3-point bony relationship, right? Okay, everyone with me, let's try to do this thing together. Okay, you have to hold 3 fingers. Okay, you'll have to hold it in this way. Take your hand, okay, place it below. With your middle finger and the thumb, you will be touching your condyles, right? Both the condyles. With your index finger, you will be touching the olecranon fossa, right? Over here, right? Now, flex your hand and simultaneously with me, try to extend it. Can you see that this becomes a triangular structure, like which is tangent or which forms a 90 degree or a right angle? Right? to the imaginary lines of both the condyles. This point over here, the olecranon part over here of the ulna, this forms the 90-degree angle with your both the condyles, right? Now when you try to extend it, this comes into the same line plane, right? Is everyone with me over here? So this is exactly which happens over here, right? So this point is absolutely intact. Like say if you have a patient, you will be like, yeah, the patient is having a supracondylar fracture or a lateral one or a medial one. It's very simple. अगर lateral या medial अगर disrupted रहेगा तो सीधी सी बात है, right, कि this bony structure won't be into the same line structure. But if this thing is getting maintained, so this structure is absolutely maintained in your supracondylar fracture. Over here there is no problem. The problem is from over here, from the metaphysis of the bone, right? I hope we are clear over here. So this 3-point bony relationship is maintained over here. All right. Okay, fine. Now how do we fix this? Either we close, reduce. If that thing is not possible, we use the Kramer's wire or the Kirschmer's wire, right? The Kirschmer's wire is being used over here. We just put up a X. And why do we use these wires and we do not permanently fix it? Because this fracture is much more commonly onto the fall on the outstretched hand, and fall onto the outstretched hand fractures are much more common in children, right? That's the reason they have what? Physis. So it depends upon to the age, and this is how we manage. When we put the Kramer's wire, we are just trying to maintain the bony structure. So when the bone reunites, it forms into the same plane, right? Although it is a weak bond, it's not a very strong bond like the screws and the plates, how we fix it. But then we also have to make sure that the child is into the growing age. If we completely fix the bone, it will be really difficult for the child. Like we can see different symmetry into the anatomical structures of those children, right? Okay, so we want to avoid that. Okay, chalo, perfect. Moving on to the complications. What are the late complications? This is one of your exam questions. Now, when there is a supracondylar fracture, what we see is the cubitus varus. Now, everyone knows what do you mean by the term varus? Reduction into the angle. Imagine this to be my arm, this to be my forearm. Now, this is straight, okay? Now, suppose there was a supracondylar fracture of the humerus, okay, into my hand, and it wasn't managed properly. So what is the late complication? This is how the bone is going to develop. There will be a reduction into the angle, okay? This is called what? Cubitus varus over here, okay? Cubitus varus or the gunstock deformity. Okay, we'll be coming on to that one. I hope myositis ossificans, everyone knows this term. It is the calcification of the bony tissue. The muscle tissue, it is getting calcified, okay? So it is nothing, but you guys have studied it into your pathology classes as well, right? Okay, fine. Most common cause which happens over here is your supracondylar fracture. Okay, that's the reason we tell, you know, like घर पे जो दाई होती है, the nannies which come into the Indian houses, we tell them कि जब massage करते हो, so do not exert pressure over here, because the bones of the children, the metaphysis, the physis, those part of the bone, they're spongy, they're weak. If you break them and to reunite that part, it becomes very difficult. Generally, it won't reunite like the original one, but then there will be certain deformities that the child will be facing it into his future years. Okay, so that's the reason it is one of the most important fractures, and it is advised. That's the reason a pediatrician will always advise the mother and to the family that do not exert pressure onto the children or do not carry any kind of massage. Okay, okay, fine. Sure. Now the Folksman contracture, we know the cock-up splint that we'll be using, the buckle up splint that we are using over here, right? Okay, fine. This is your fracture of necessity. Anyone, is it an intra-articular or extra-articular fracture? Absolutely right, it is an intra-articular fracture. You can see the joint space is involved over here. Okay, this is your fracture of necessity. Okay, over here when you talk about this, your epiphysis, metaphysis and the physis, all when the three structures are involved, this is your Salter and Harris type 4 fractures. Okay, Just revise this type. There won't be a straight question, but maybe a complex question which can generally be asked, okay, for the fracture of necessity. Right. So what are the complications over here? Into what fracture are we talking about? The lateral condyle of the humerus. Now the late complication over here is cubitus valgus. Now valgus is what? When you talk about this to be the hand angle, and when say this gets increased, this is decreased, this is your gunstock deformity. Okay? This is happening in which one? Your supracondylar fractures, right? This is the increase into the angle. Okay, this is the normal one. This is decrease in angle. Cubitus varus, this is cubitus valgus. Okay, this is happening in which fracture? Lateral condylar fracture of the humerus. Okay, just make sure these are the only questions that you will be having in front of your screen. This is how it's going to look like. Now when you say decrease into the angle, can I say the hands are going to look like this? Right, now say this is to be the arm, this is to be the forearm. Now the angle is getting decreased. This is the gunstock deformity, right? Cubitus varus, the late complication of supracondylar fractures, right, of the humerus. Now when there is increase valgus, right, this is how it's gonna be, right? This is how you can see the child. Am I clear over here? Okay, sure, perfect. Moving on. Another one condition is the pulled nursemaid over here. What we have is the hand is generally of the child, it is locked into the pronation, because when you lift the child, you hold him like this, right? You hold him like this. So that's why it is in pronation. And when we have to fix it, we have to supinate the forearm. All right. So you guys can read about this thing. Now coming to one of your favorite fractures. Come on. Right now in front of your screen, what bone is involved and what fracture is it? Yes, we'll be coming on to the nerve section. I'll be explaining that palsy also over there. We'll be quickly covering up the important aspects which is necessary right now for your exam. Okay. Ulnar bone. Okay, this is which fracture here? Right now in front of your screen, your important one, Montija. This is also known as the fracture of necessity. The upper 1/3 of the ulna or the lower 2/3 of the ulna. Generally we say the upper 1/3 of the ulna. Okay. When it comes to the radius, that becomes your Galeazzi, the lower 1/3. Okay. This is the proximal, this is the distal. So the distal 1/3 of the radius bone, this is your Galeazzi fracture. Okay. Can you see it over here? And when it comes to the very distal part where your radioulnar joint is involved and where your the carpo-radioulnar joint is involved. And when you have a fracture over here where you see it in the bluing, generally it is within the radius of 2 centimeters. That is your Colles fracture. Okay, we'll be seeing this one also. So am I proving my point? This joint is completely distorted and you can see the bone over here. It is very distal part of the radius, right, towards the styloid process. So this is your which fracture? Colles fracture. Okay. Okay, fine. Okay, just try to know one thing. Colles fracture is also much more commonly seen into the osteoporotic patients. All right, it is a very common fracture that you see in them. If you do not fix Colles fracture, it will become a dinner fork deformity that we generally talk about. It's a complication if we do not fix Colles fracture, right? So these are just the one-liners that you can read. Okay, fine. Okay, the another one of the important aspect, this is your scaphoid bone. Okay. Now what part of the bone is going to generally get affected? Which part is having the highest risk of avascular necrosis over here when we talk about? It is your proximal part of the bone, right? The waist is very commonly getting fractured, But the one which will get avascular necrosis because the blood supply is coming from the distal end to the proximal end. So in the fracture of scaphoid, what is the complication? Avascular necrosis. If we do not maintain the circulation back again, we can see that there will be avascular necrosis into the proximal aspect of the bone, right? Okay, fine. All right. It is, just in case, know the name Herbert screw. It is used into the fixation of the scaphoid fractures. Okay, it is if the bone is completely displaced, like say this is the general bone, but if this was fractured and you have one part over here and one part over here, so you try to get this back and you fix it with a screw over here. All right, so this is the Herbert screw that we use over here. All right, as we all know, what are the complications of these fractures? Non-union, avascular necrosis. We have discussed this thing into details, right? And the wrist osteoarthritis. Fine. Can anyone differentiate when you see this term in front of your screen? Neck of fifth metacarpal. When it comes to fifth metatarsal, it is your Jones fracture. When it comes to your fifth metacarpal, this is your boxes fracture. It is much more common in boxers. The ones who do boxing, they are having high possibility to injure the neck of the fifth metacarpal bone, right? Okay, chalo. Mallet finger or the baseball finger, over here basically your DIP, okay, the distal interphalangeal joint, it is hyperflexed. Okay, now you want to fix it, you will be applying up a splint. Okay, this is hyper extending the finger, right, so that the finger can stay like that. Okay, so these are some of the important terms into your upper limb traumas, the ones that we discussed initially. Excuse me. They're surely giving you at least 1 to 2 questions when it comes to the examination point of view, right? We'll be taking a small break. Do you guys want that, or should we just continue? Because I think that you guys have another class at 5. So I just want to finish the important fractures around the hip, right? Or let's quickly do this. Fine. So you guys will be covering the very important aspects into orthopedics, giving you some of the very important questions into the exams. In case if we have some couple of minutes left, we will be quickly running through all the radiological important images as well. And after this session is done, I will be completely dedicating myself to you guys in terms of image-based questions. So I'll be trying to take 3 different sessions before your exams. Each session would be comprising of roughly 80 to 100 images. So we'll quickly run across more than 300 images. So that would be like 3 sessions, 300 images. Surely you guys are getting at least 80 to 100 images this time into your exam. So this comprises 30% of your examination question paper. All right, fine. So when it comes to radiology and orthopedics, you guys, I'm pretty much sure that you're revising very well and you're focusing on to the images as well. So just the radiology itself is going to give you at least 30 to 34 questions this time. Into the August exam, the radiology questions were 44 in count. Okay, so it is one of your important subject aspects which gets which enhances its boundaries into many other subspecialties as well, right? So it is very important to understand that, so you can answer the surgical questions also, the radiological questions related to anatomy, or to the orthopedics, to medicine, to obs and gynae, and into many other subjects. All right, so should we continue? Okay, right now this is image specifically dedicated to orthopedics itself, but then as I've just discussed, I'll be conducting that session as well. Okay, from all the subjects, at least we'll be I'll be trying to take account for at least 8 to 9 subjects, the major subjects which that we are seeing that many questions are repeatedly getting asked into your examinations. All right. Do not worry onto the images. We'll be covering it up. That's the reason that I've kept it towards the end. We'll be discussing microbiology, some important images, pathology, because I know those images are very boring. It was boring for me as well. And then वही subject था जिससे मैं हमेशा दूर भागता. But then these days they're not giving you that one-liners kind of questions from microbiology, but rather they're giving you an image, because the subject का जो importance है वो उसके image में ही है, right? Because these are the changes, these are the signs that you see on the slides, right? So you cannot just expect those questions to be one-liners. Even though if it's been asked to you in a one-liner form, you will certainly have an image this time in front of your screen. ठीक है? चलो. Fine. So let's start with this one, your fractures around the hip. Okay. The most one is your neck femur fracture. Okay. This is happening over here. So this space that you see around you, this is your capsule, right? So this is your intracapsular fracture. And the fracture that right now I'm drawing over here, this is your intratrochanteric fracture. Now, what do you mean by the trochanterus? This point over here is your greater trochanter. This one is your lesser trochanter. So if any fracture happens between that, this is your intratrochanteric fracture. Now the two important aspects is, सीधी सी बात है, this is the head of the femur, right? Now when this fracture is involved, this involves the joint space. Joint का movement disrupt हो रहा है, right? So that's the reason it is your intracapsular fracture. And the intertrochanteric fracture which happens over here, right? This doesn't involve your capsule space, and this is your extracapsular fracture. Okay, just these 2 pointers. Remember this. We'll be seeing the images as well. This is how these fractures look like. The intracapsular, intratrochanteric. Right? Okay, sure. There's two thumb rule. Into young adults, we generally do not replace the entire joint structure, right? Because we know if we can just fix the fracture, what is best, to put the prosthetic or to maintain the original joint? It's obvious we'll be maintaining the original joint. Why? Because we have the blood supply and everything. And why do you want to hamper the young person's life, right, by doing that? So there are different criterias where we consider like open reduction and completely or partially hemiarthroplasty or complete hip replacement. It depends on to the condition and to the age factor, the motility and everything. All right. So let's have a look into that. If the fracture is undisplaced, obviously it is close reduction. We won't be opening up the patient, just close reduction plus internal fixation with screws, right? So if you can see in front of your screen, this is how we will be putting up the screws. So this position just stays maintained, right? So this is the head, okay? This is the head of the femur and this is the shaft. So just by putting up the screws over here, we are just maintaining the angle and the position, right? Okay. So moving on, if it's displaced, so it depends on to the age that I just told you guys. If it is displaced, the age is less than 55 to 60 years, what we do is closed reduction, right? Closed reduction. If the patient is having osteoporosis or any other bony complication, we might even open reduce this patient. This is a very dicey topic, so it depends on to the clinical picture, and that's how we'll be taking the surgical decision onto these patients, right? And obviously we'll be also fixing these patients with screws, right? Now, if the patient is more than 60 years, now you know that 60 years ka hai already, they have so many issues, and when it comes to the bony aspects as well, right? So what we do is we see if the patient is having arthritis or not, the osteoarthritis, right? If the patient is having some ambulatory movements or not, based on that we do either hemi. Hemi means we just replacing the head of the femur. Okay, in complete we are also replacing the capsule, okay, the acetabulum, right, of your pelvis, right? So that part is also getting replaced, and also the head of the femur. Both the structures are getting replaced. Okay, fine. So we look for the conditions over here. If the patient is elderly patient with limited ambulatory capacity. Now, when do we do the total hip arthroplasty? When there is active ambulatory status. If you have this question, the patient is having passive ambulatory status, and if they give you both the options into the same condition, make sure you read the question very well. Will you go for the hemiarthroplasty or to the total hip arthroplasty? Obviously, if the movement is limited or it is passive, you will go for hemi. If it is very active, we can replace both the parts. So उसमें useful है, right? Because already the age factor is above 60. So when you're replacing both, why you're doing it? Because you know that the patient is ambulatory. His movements are active movements. That's the reason you would be taking this conditions, right? Or if the patient is having pre-existing hip arthritis. Okay, these are the only two conditions. Fine. This is just a classical picture. This is your hemi half. And this is check. We are also replacing the joint completely. This is your total hip arthroplasty. Okay? Are we clear over here? Fine. Everyone knows neck femur fracture. What is the complication we have? Avascular necrosis. Everyone is absolutely aware about that part. So now coming on to intertrochanteric fractures. Okay? As we discussed the lesser and the greater trochanterus के बीच में अगर कोई fracture हो रहा है, so this is the fracture which generally takes place, right? There are two important muscles which are getting attached. Okay, this is your iliopsoas muscle. Its prime function is to the flexion of your hip joint. Okay, this is happening due to iliopsoas muscle. Okay, when it comes to these two muscles, your gluteus medius and minimus, what is their function? Abduction. And there is one test which is positive when these muscles are generally involved. What is the name of the test? It is the Trendelenburg's test. Okay, this test is positive is if the patient is unable to abduct. Okay, and it is not being done by gluteus maximus. Remember that point very well. Okay, okay, fine. Now यहाँ पे भी हमने initially क्या किया था? If the patient is between 55 to 60 years, we will try to close reduct or open reduct depending upon how the clinical picture is. Youngsters में we will do close reduction with screw fixations, right? Now the same thing we are doing over here, but we have to also preserve the angle, right? So we do not involve the further or the late complications, right, of the varus and the valgus. That's the reason we will be fixing it with the dynamic hip screws. If you can see it over here, this is your dynamic hip screws, right? This is how we fix the head. Okay, the physis, it depends upon to the age, which is generally not commonly seen, but epiphysis, the metaphysis and the diaphysis, all these three structures are intact into the identical plane. All right, fine. So as I told you, if the angle gets decreased, it's going to be coxa varus. If the angle is going to get increased, it's going to be coxa valgus. This can be the further complications if this management is not taken place correctly. All right, okay, fine. All right, I'm proving my point over here. Okay, fine. Now depending upon to the age, we have different management. If the patient is less than 2 years, we saw this, if you guys remember, this splint, right? Gallows or the Bryant's traction. We make the patient or the 2-year-old baby lay down or supinely onto the bed. We just raise it 90 degrees into the air and we just put up the traction. Okay, this is how we will be fixing up into these patients. Okay, now if the child is more than 2 years, we put up 1.5 fracture over here like this. Okay, can you see this one? This is called your hip spica. Okay, 1.5 fracture in more than 2 years. Okay, now you would be like ki between 2 to 14, what is the criteria, right? Now between these children, we put up the titanium elastic nailing system or the TENS. Okay, now you would be surprised like yaar metal hai, how is it elastic? So remember this point, titanium is the only metal which we use or the preferably we use for the surgical procedures, because with time it is one of the most flexible metal which can adapt to your body postures. All right, so this is the strings or the titanium elastic nailing system. If you can see these wires, this is how we put it. Okay, so we preserve the physis so the child can eventually grow during that span. But if it is more than 14 years, okay, we might take this decision of interlocking. Basically, we just put up the rods and we fix it up with two screws. All right. So we'll be fixing. So over here, obviously, the child will be having problem to grow in height. Okay. So that's the reason we generally try to do it more than 14 or preferably more than 18, because till that age we know that these children are going to grow into their height. Okay, fine. All right. The later complications, we know if the neck femur fracture happens, hypovolemic shock due to blood loss of more than 1 to 1.5 liters. Everyone knows this part very well. Okay. The other complication is snowstorm. This was one of the exam questions. Youngster underwent a road traffic accident. Immediate management was taken place into this patient, but he suddenly develops respiratory distress, and the following radiological images show the following sign. What do you suspect is the complication of what condition into this patient? This was one of the examination question that given snowstorm appearance, a classical picture which happens in fat embolism syndrome, right? I'll just give you that quick picture that how it looks like. We have discussed this thing into the previous class also, right? This is the classical picture of your snowstorm appearance, a complication into femur fractures leading to fat embolism syndrome. The other one is your ARDS, right? So just quickly go through that class also if you want. It's a very short class, so you'll come to know what we are talking about, right? Fine. So now coming to the knee anatomy, we know we have some important ligaments, right? The lateral collateral, the medial collateral, the anterior cruciate, and the posterior cruciate, right? Which one is the most common to get affected? The anterior cruciate ligament. Okay, fine. All these ligaments, they will be preventing the different movements. The medial collateral ligament will allow the foot to stay just intact. So say if your leg is moving towards the outside part, it is the lateral collateral ligament which is going to protect you. Say this is the medial aspect. So over here, if the leg is trying to move over here, if it is trying to get outside the socket medially, so your medial collateral ligament is going to protect your leg. Okay. If there is translation of the tibia, if the tibia is trying to move outside anteriorly, it is your anterior cruciate ligament which is going to protect. And if it is trying to go posterior, it is the posterior cruciate ligament which is going to protect. Okay. I hope we are clear over here. So there are different tests. So सीधी सी बात है, we'll look over here when it comes to your medial cruciate ligament. Now you will be like, how do I excuse me, remember these points? Okay. So now when it comes to your medial cruciate ligament, okay, there is this force pointing the tibia outwards, okay, outwards and medially. Okay. Now medial has got, I know this might sound a bit weird to you guys, but then I don't know how you will be remembering this. Maybe you can do is like, since the tibia is going towards the outer aspect into the medial dislocation. Right now, do not get into the concept. It's slightly difficult to get into this thing right now. Just remember MCL is having your valgus. Okay, valgus force. So what stress test we do over here is valgus stress test, is the 30-degree movement of the leg we do for the medial one, valgus. Okay. When it comes to the lateral L, I don't know how will you remember that. Lateral is having the varus stress test. Okay. Varus is for the reduced angle and valgus is for the increased angle. Okay. Now what happens over here when you have the knock knees? This is your valgus. Okay, the angle is increased, that's why you have the knock knees. If the angle is decreased, this is how the patient is going to be, right? This is your varus, this is your valgus, this is your varus. Okay, valgus, varus, valgus, varus. Okay, just make sure you know this point very well. Okay, so ACL is the most common ligament to be getting injured over here, right, into the twisting. Knee injury, generally when the knee is generally flexed and is not hyperextended, when it is slightly flexed, this is how the tibia is gonna translate anteriorly, okay, out from the femur joint. All right, okay. So we have certain tests that we undergo. You can have a look upon to these tests, because these tests might be just a one-liner questions. But over here, I'm trying to give you guys the image. This is very important. This is your normal ACL. This is how this looks like. And this is the toned part of the ACL. I also have one more picture over here. There is one important condition which happens over here. Okay, we'll be coming on to, okay, have a look over here, right? This is your medial ligament, okay? The meniscus, the medial meniscus, all right? Now, if you look over here, check for this now and check for this and this. Can you see that this part is distorted over here, right? Have a look onto it once again, right? This is a MRI scan. Why? Because we're looking for the meniscus. Now, meniscus are what? Cartilageous structure. Now, cartilage is what? It's a soft tissue. So this is a MRI scan, right? So we'll be doing arthroplasty into this patients, right? Arthroscopic management will be taken up, and this is how the arthroscopic management looks like into the clear picture. We'll be just cutting down a fragment of the meniscus so the joint movement is retained and the patient is back to his normal movements back again, right? Okay, fine. So now there are certain tests when it comes to the meniscus and to the cruciate ligaments. Let's try to have a look upon to the Lachman's test. Is basically, when do we do it? See, this is baat hai. When we talk about the anterior ligament, now say this is your upper limb, this is the lower limb, this is the femur and the tibia and the fibula over here, right? So now you try to flex 30 degree. Okay, when you try to do the flexion of 30 degrees, this is the drawer's test. But if this thing is not possible, we slightly try to flex it 5 to 10 degrees, and this is your Lachman's test. Nothing rocket science over here. Okay, just the name, 30 degree drawer's test, 5 to 10 degrees Lachman's test. Okay, I hope we are clear over here. Okay, fine. Okay, I'll be giving you this thing so you can read about it. Okay, now when it comes to meniscus, it is the middle meniscus which is much more commonly injured, right? Now, as we saw, the bucket handle tear, it is much more commonly seen. This is the bucket handle. This looks like a bucket handle. Okay? This generally involves into the middle meniscus injury. Okay? Posterior horn of the middle meniscus, right? Now, generally, the meniscus is avascular structure only to the proximal aspects. They receive nutrition from the synovials. Okay, just a not an examination question. Just letting you know as a point of knowledge about how the meniscus function. Okay, fine. So, what are the tests? McMurray's tests are for the meniscus. Okay, just know the test and what are the changes that you see. That's all you need over here. Okay. The main part is was into your upper limb that we covered the condylar fractures, and over here was the intertrochanterics and the intracapsular fractures, right? Okay, fine. So this is how the meniscus are generally fixed. Okay, meniscectomy is being done as the treatment of choice. So the mobilization is maintained and the patient can move, because this meniscus will further grow and this is going to give patient the problem. He won't be having flexibility into the movements. That's the reason you need to just cut the part which has been disrupted, just a minor fragment, and you just maintain the joint movement. Okay, okay, fine, sure. So talking about the TB, these are just the one-liners which you guys can read. Okay, talking about the osteomyelitis, we know it is spreading through which route? Through the hematogenous route. Okay, it is much more common into the metaphysis, much more commonly seen into children. Metaphysis, the soft or the spongy part of the bone, right? Initially what's going to happen, the skin involvement is there. Okay, तो skin धीरे धीरे थोड़ा थोड़ा पतला होते जाएगा. ठीक है, it's gonna get slightly slim. You will see like a regular oval structure, like cavity structure, जहाँ से pus drain out होगा. ठीक है, it will be soft initially into the acute phases. Now the management involves what? सीधी सी बात है, it's a infection, a bacterial infection. We will be treating with IV antibiotics into the hospital for certain long duration, up to 6 weeks, 4 to 6 weeks, and then uske baad for 6 to 8 weeks we give oral antibiotics. And if the treatment is not, this course of treatment is not completed, this might get prolonged into chronic osteomyelitis. Okay, now over here the structures becomes irregular. Okay, we have certain radiological changes that we'll be seeing into these patients. Okay, so now we know inflammation है, ESR, CRP, DLC बढ़ रहा है, medicine, it is very common sense. Okay, fine. So the earliest X-ray finding is loss of normal tissue structure. Okay, this is how we see, this is how the X-ray is. No one's going to ask you the X-ray, but try to focus at the periosteal reaction. This is the earliest bony change that we see. Okay, this is the periosteum, right? Focus over here onto this structure, right? This changes, these are the changes that we generally see into these patients. Okay, now if we, okay, MRI is the investigation of choice. Why? Can anyone tell me? Looking for the soft tissues, the tissue structures related to the bone, the periosteum, and the fluid inside it. We will be doing MRI as the investigation of choice. Hotspot, if it's an active thing, we call that thing as hotspot. What do we call cold spot as? Obviously, when it comes to your avascular necrosis anywhere into the body, we call those structures as cold spots. So that's the reason, even when we try to identify the tumor and we use these technicians into these patients, the tumor will pick up the glucose, and the points that we see, those are the hotspot points, okay, and not the cold one. Cold ones generally involve the avascular necrosis, right? Okay, chalo. So let's quickly finish just the important points over here, and I'll be sharing you guys these points. I know that you guys have a class at 5. Okay, so one of the radiological changes, that's all we'll be looking over here, which is just relevant and important in terms of examination. Give me 5 minutes and we are finishing. Okay, so theory, you guys can read about it. Okay, sequestrum is the dead bone. Okay, this is generally seen into the chronic phase, as I've told you guys. Okay, so now this thing has got a canal which is called, okay, I'll show you in this picture. Yeah, this is the sequestrum and this is the cloacal. Okay, that is the जो बोलते हैं ना नाला, or the canal for the pus to drain out into the chronic cases. Okay, all right, now looking on to the one of the important topics. Okay, this is radiolucent, that was radio opaque. Opaque मतलब वो calcification हो रहा है, that's the reason it is radio opaque. Now radiolucent, this abscess you see it in subacute osteomyelitis, when the chronic stage doesn't compensate well, we develop subacute osteomyelitis. Okay, this is not involved with any kind of pus. Okay, all right. Okay, moving on to one of the important examination questions, pot spine. Come on, over here, pot spine, what's happening over here? This is generally involved into TB spine, and what part is involved? It is the vertebral body. ठीक है, वर्टेब्रल बॉडी का इन्फेक्शन जनरली हो रहा है, इसीलिए वो चीजें हमें वर्टेब्रा में ही दिखेगी. यू विल बी सीइंग द स्प्रेड बाय Bateson's plexus. Remember, abdomen, thorax, pelvis, whatever the spread is going to be, it is from the Bateson's plexus. That's the reason we discussed in radiology when it was associated with your prostate cancer and the breast cancer. What was the route of the spread? Through which plexus? It was through Bateson's plexus. Okay, just a thumb rule, you have to know it. Okay, fine. So pot spine, a classical picture that you see in into TB spine. What is the picture that we see in ankylosing spondylitis? Come on, can anyone? Ankylosing spondylitis, what is the spine appearance that we see? We see is what? Which one? Come on. It is the bamboo spine appearance. Okay, we'll be absolutely right, Twinkle. It is the bamboo spine appearance. Okay, chalo. So do not get into too much of details over here. Just know the radiological images, because this is not the right time for you guys to get into the theory right now. Whatever files I'll be sharing, go through the radiological images. We have covered 90% of the orthopedics class over here, including my previous session. Okay, in case if you have any kind of doubts, go over there. It's a very short class. Go, you will be understanding the details about how the orthopedics works, the bone, the basic structure, the fracture healing and everything, the complications. This is what we started over there, right? And over here we finished one of the most important concepts and the topics. I'll be sharing you arthritis and the tumors. Tumors have made just 2 pages. Go through these points. I want that when you revise orthopedics later on, it should not take you more than 3 to max 5 hours. Okay, because make sure at this point of time you would be revising 2 to 3 subjects in a day when it comes to the minor subjects. Okay, if you're taking up a major chunk, pick up 1 major, pick up 2 minor. Okay, but you're not supposed to finish 1 major into 1 day itself. Keep it into the span of 3 different days. Okay, this is how you can divide your medicine, surgery, obs, gynae, your 3 major subjects. Divide it into the span of 2 to 3 days. So in the span of 9 days, you're finishing up these 3 important subjects. Plus, you are revising twice the minor subjects, right? If you study 3 minor subjects every day, okay? This is the absolute key for the success over here. Do not skip any of your minor subjects. The score that you see exam mein 140s, 145, this is the hard luck that if you study the minor subjects very well and thoroughly, it will definitely either land you between 170, 180s. It can also take you beyond 200s. So the key for this examination, it is to focus onto the minor subjects and get thorough with that, because you will not be losing any marks into the minor subjects. Okay, fine. So I won't be taking much of your time. करेंगे will be बहुत सारे बातचीत गपशप सब कुछ करेंगे. Right now, what we'll do is I'll give you guys a breaks before you guys start with your another session with surgery. In the next session, whatever I'll be taking, it will be core images. Okay, we won't be discussing anything, just quick one-liners or the important points associated with that image itself, but no theory into it, because we'll be covering up like approximately 100 to 110 images into per session itself. All right, so I want that session for you guys, so that this pattern which has been changing these days will at least help you give 30% of the examination questions straight into your pocket. Okay, chalo, it was really nice having you all. I hope you guys enjoyed the session. Take a nice good break, a tea break, and all the best with your preparation and for your next surgery session. All right, okay, I'm signing off right now. Okay, bye everyone.